is kind of the Reader's Digest version of electrocardiography. It's going to be a basic introductory discussion. There's a handout at the back of the room. I think there's still some there. Everything that I'm going to say is in that handout, so you don't have to write anything down. And it will also contain graphic examples of some of the stuff that that we'll talk about, so you can refer to that if you need to. To begin with, when reading an EKG, you really have to have a systematic approach to it. If you just grab an EKG, lay it in front of you, and hope that the major abnormalities will jump off the page at you, you're going to miss most of the things, most of the information that's available to you on an EKG. Now, this is kind of my system. I look at rate, rhythm, and regularity, then intervals. Mean electrical axis, we'll spend a lot of time on that because it's a very important principle. Look for evidence of block at the level of the AV node and within the ventricles and the QRS. Evidence of hypertrophy, infarction, ischemia, and lastly looking for drug or electrolyte effects. Now, Dubin has rate, rhythm, axis, hypertrophy. Whichever text or method you use, as long as you have a systematic approach, that's fine. The major assumption of EKG is that the body is a uniform conductor. Now, it's not a valid assumption, but it will influence how we're going to discuss some of the morphologies in P waves and in QRSs. And to start with, the original lead sets that were used for EKG were called bipolar leads. Bipolar because you had one plugged into negative, one plugged into positive. Now, when they're bipolar, that means they can only see what happens electrically in the direction they're looking. So it's essentially like looking down a tube, and if somebody's waving their hand up and down, you only see what their hand's doing when it's in front of you, in front of the tube. So bipolar leads can only see in the direction that they point. And if we put the bipolar leads on the arms, right arm to left arm, then that lead can only see what's happening in a horizontal direction. Now, the heart electrically acts like a battery that changes voltage over time. So when it does so, it creates an electrical vector. This lead, this bipolar lead, is only going to see what's happening in its own direction. Right arm to left arm is designated lead 1 and horizontal to the ground, so we'll use polar coordinates to describe that and call that 0 degrees. From right arm to left leg is lead 2, so we're counting upwards in a counterclockwise direction. And we have then essentially a setup that allows us to surround the heart. So right arm to left leg is lead 2, and then left arm to left leg is lead 3. Now, we've got these hooked up arms and legs, so we've essentially drawn a triangle that surrounds the heart. And we can assume that that's an equiangular triangle, and if we do that, we don't have to memorize any numbers. We go from 0 degrees, and since it's an equiangular triangle, this is going to be 60 degrees, and then here 120 degrees. The reason that's important is a lot of your descriptions, a lot of what we're going to describe with P waves and QRS, we're going to describe what direction things are pointing. Now, to make it a little bit easier, we have a second set of leads that are attached to the limbs. It's the same leads, but we're going to hook them up a little bit differently. Now, instead of going from one arm to the other arm, I'll go from my right arm and left leg and look towards the left shoulder and make funny noises. If I do that, I have to augment the voltage a little bit, and we'll call it augmented voltage left arm. Meanwhile, if I go left leg and left arm to the right arm, augmented voltage right arm, and both arms looking towards the foot, given the clever name augmented voltage foot. Now, the reason those are useful is because they bisect the original angles of Einthoven's triangle. That allows you to get direction down with a lot more accuracy. And the ones that we're really going to be using are lead 1 and AVF. Now, when we do a standard 12-lead ECG, we also have leads on the chest. These leads are placed essentially surrounding the heart, and now my negative pole is going to be plugged into both arms and the leg. So I'm looking from an average point of essentially slicing the body in half towards, say, V1. or V2 or V3, slicing the body in half, looking towards my exploring lead or my chest lead. Now we could go through polar coordinates and describe what happens in the chest leads. However, that's not been as well developed and it's not as useful clinically in describing the EKG. So to start with, mean electrical axis. When you determine the axis, the easy means of doing it is to look at lead 1 and lead AVF. Because if the net QRS is positive in lead 1, that means the heart's doing something in the direction between the right arm and left arm. If I do the same thing with AVF, then I can essentially assign a quadrant and say this heart is doing something in the left upper quadrant or left lower, or right upper. Now when you do that, if it's in the left upper quadrant, and we're going to define that a little bit further later, it automatically brings to mind diagnosis. So if I see positive in AVL and negative in AVF, automatically I'm thinking left ventricular hypertrophy, inferior myocardial infarction, or something we really won't touch on today, anterior fascicular block. So if I get right axis deviation, so I'm negative in lead 1, positive in AVF, automatically I'm thinking right ventricular hypertrophy, lateral myocardial infarction, or a posterior fascicular block. So axis immediately starts pointing out some diagnoses on the ECG. Now using that 1 in AVF method, I'll ask you, what's the axis here? Is it normal or abnormal? Well, I heard some murmurings. Normal? Okay. Now with a little bit of practice you can go from just normal to giving me a number, and before long it'll take you about 2 seconds to look at the EKG and say the axis is 60 degrees or the axis is 120 degrees. So we use lead 1 and we count what's above the 0 line here and subtract what's below the 0 line. That gives us a net value for the lead. So here in lead 1 we're a net positive maybe 1 or 2. Then I go to AVF and it's all above the line, so it's all positive. So I'm pointing towards AVF in lead 1. So my true direction then is somewhere in that left lower quadrant. Now you find the lead that's isoelectric. You take what's above the line, subtract what's below, and you have a net 0. So then the heart is doing something at 90 degrees from that lead. Now we look for the isoelectric lead here, and it's AVL. And I know from Einthoven's triangle and bisecting my angles, I don't have to memorize. Well, after you do it a while, you do have it memorized. But I know AVL points at minus 30 degrees. So 90 degrees away from that then is an axis of 60 degrees. Leads 1 and AVF assign the quadrant, then find the isoelectric lead, and you've got your mean electrical axis. So it's really very easy. Now we could, as I said, do the same thing over in the chest leads or in the horizontal plane. We would find that V6 is positive, V1 and V2 are negative, so we're pointed towards the left, the kind of posterior, left posterior quadrant of the chest. The isoelectric lead here is V3, and it's normal for our mean electrical axis to be in this posterior quadrant because the left ventricle is dominant. It's got a lot more meat than the right ventricle, so it essentially swallows up what the right ventricle is trying to do. So this is the normal appearance that we expect to see in our chest leads. Now I'll ask you again, what's the mean electrical axis? Well, to start with, is it normal or abnormal? Now, I told you that anything in the left upper quadrant was kind of a left axis. In truth, there are a lot of non-cardiac diseases like obesity that can shift the axis slightly because of a shift anatomically. And an axis between 0 and minus 30 degrees is seen very frequently in non-cardiac illness. So minus 30 is kind of set as the threshold for pathologically abnormal axis. So if we do the same thing again here, lead 1 is net positive. Lead AVF is net negative, putting us in the left upper quadrant, but now we have to go to arbitration. So we go to lead 2, which you know points at 60 degrees, and if lead 2 is net negative, then I know I'm pointing away from lead 2. Here it's isoelectric, so I know my axis is right at minus 30 degrees. When you look for left axis deviation, you go to 1, 1 is positive, AVF is negative, then you turn to lead 2. If lead 2 is negative, pathological left axis deviation. If lead 2 is still positive, it's still a socially acceptable axis. So one more time. Axis normal or abnormal? Very much so. Can you give me a number? So, yeah, excellent. That's 120 degrees. So we're negative in 1, positive in AVF. Puts us in the right lower quadrant. AVR is isoelectric. It's at minus 150. So that gives us an axis of 120 degrees. You see, and that's right axis deviation. Now the threshold for pathological right axis deviation in adults is 105 degrees. There's nobody isoelectric at 105. So in order to call a pathological right axis deviation, I like to see AVR very nearly isoelectric or isoelectric. You see that, automatically you think, I wonder if this is right ventricular hypertrophy, or is there lateral myocardial infarction? Okay. Now, moving from axis, though we'll get back to it over and over again, we're going to talk about morphologies, and to start with, we'll talk about P waves. When your heart begins depolarization, it starts at the SA node, which sits kind of like one of those pillows you wear on an airplane, right at the junction between the SVC and the right atrium. It starts depolarization from the right upper to left lower, and at the same time follows a specialized conduction system to begin activation at the left atrium. So the right atrium starts its depolarization, the wave sweeps downward, and then the left atrium starts its depolarization from the right upper pulmonary vein and also sweeps downward and to the left. That allows us to look at lead 2, which is parallel to the direction of both of those activation waves, and it's going to give us the best view of the P waves in the frontal plane. So I start right atrial depolarization, and then with a little delay I've got left atrial depolarization, and we see essentially there's some in lead 2. So it's normal, lead 2 is the best lead to see the P waves, and it's normal to see a little bit of notching in the P wave. Now V1 sits right over the right atrium, so it's going to get to see right atrial depolarization coming out towards it, and with a little bit of delay, the left atrium, which is the most superior and posterior aspect of your heart, it depolarizes away from V1, so we may see this sine wave appearance, and that's perfectly normal. When the right atrium gets big, our P wave's going to grow in height, but since the right atrium kicks things off first, we're going to see the P wave grow tall, but not really spread out. So what you get to see with right atrial enlargement is this very tall P wave that's pointed, and it's 2.5 boxes tall in lead 2. Now why 2.5 boxes? There's no magic to that. That's just the value at which sensitivity and specificity are at their best. If we go to V1, our right atrial depolarization is augmented, so the first half of our P wave grows tall and pointed, greater than 1.5 boxes tall. This is an example. I'll ask you here, is the axis normal or abnormal of the QRS? It's abnormal, right? So we've got a QRS that's net negative in lead 1. It's net positive in AVF. It's even net positive in AVR. So this is very steep right axis deviation. Automatically you're thinking right ventricular hypertrophy, which is what this patient had. But as soon as the EKG comes up, your eye is drawn to this P wave. Very tall and pointed, at least 3 millimeters tall. If we go over to V1, we look at the initial part of our P wave, and it's 2 millimeters tall. So good evidence of right atrial enlargement, which frequently accompanies right ventricular hypertrophy. This patient had evidence of pulmonary fibrosis creating pulmonary artery hypertension in RVH. When the left atrium gets bigger, it grows in size, its own individual P wave, but since it starts with some delay, what you see on lead 2 is the left atrium begins to move out from under the shadow of the right atrium, and we see the P wave grow broad and grow camel humps, at least 1 millimeter between the peaks of those two humps, with a P wave that's roughly 3 millimeters in duration. This appearance, because of the historical association with rheumatic fever, is often known as P mitrale. When the left atrium depolarizes with increased EMF looking from V1, remember it's heading away from V1, so we accentuate the terminal negative deflection. Our sine wave now grows deeper in the second half. You should be able to fit 1 square millimeter into that terminal negative deflection. It's the most overcalled finding in electrocardiography because normal people can have the sine wave appearance, so you want it deep enough to fit a square millimeter or one of the tiny square boxes into that terminal negative deflection. This is an example. You see very broad P wave. It's almost 160 milliseconds, easily distinguishable camel humps, dromedary or Bactrian, I can never remember which. Maybe one of you can. The terminal negative deflection here is almost 3 millimeters wide and at least 1 millimeter deep, so easily fit a square millimeter into that. Now, moving away from P waves, we're going to talk about QRS morphology. We'll talk about block, hypertrophy, and then infarction. To start with block, by definition, when there is a block in the ventricles, the QRS grows in its length. Greater than 120 milliseconds, or 3 millimeters, is a block. Greater than 100 milliseconds, or 2.5 millimeters, is abnormal conduction, but not yet a block, often termed a conduction delay. When you have a block, go to V1. So you're looking at the EKG, you're finished looking at the P wave and the intervals, and you find that your QRS duration is long. If you go to V1, that's going to tell you who got blocked. Because the right ventricle, when it depolarizes, has a vector that points right and anterior, so at your right breast. When the left ventricle depolarizes, it depolarizes back towards your scapula. And remember, the left ventricle usually wins, but when we separate them apart, we can sometimes see them individually. So here, if I go to V1, I cut my QRS in half, the last half of this QRS is well below the 0 line. That tells me the left ventricle is the guy who didn't get the signal to be activated. Now, once I see that it's the left ventricle, I'm going to ask the question, is it the conduction system disease that has caused this problem, or is it intrinsic to myocytes? Are they just not communicating well? And in order to define it as conduction system disease, I want to see a very typical morphology. So to start with, greater than 120 milliseconds, QRS duration, and we'll see a wide, notched, and positive QRS in 1 AVL and V6. Looks like somebody took a bite out of the top of the QRS. And a deep QS in V1. An example shown here is mean electrical axis, normal or abnormal? Normal, yeah, so it's positive here. Close to isoelectric in AVF, which should give us an axis of 0 degrees. Then we have a QRS duration that's about 3 boxes long. And we have the top here, see the terminal part's negative in V1. And the top looks like it's notched, like somebody bit off the top of our QRS. So 1 AVL, V5, V6. When you see a left bundle, that means the left ventricle is not being activated normally. And all of our diagnoses we make, anatomic diagnoses and other types, depend on knowing how the ventricle is being activated. So when you see a left bundle, that's all you can say about the left ventricle. See left bundle branch block, you say, is there evidence of hypertrophy? Well, there might be, but you can't tell from the electrocardiogram. Is there prior myocardial infarction? Well, maybe so, but I can't tell from the EKG. With a right bundle branch block, we're going to get to see the right ventricle depolarize now in all of its glory. It's no longer going to be swallowed up by the vector of the left ventricle. So what we'll see is, again, greater than 3 millimeters duration, or 120 milliseconds. Normal activation of the left ventricle, so the first half of the QRS looks perfectly normal. And then we'll see the right ventricle depolarize, which gives us an R prime in V1 and deep wide S waves in 1 AVL and V6. So an example of a right bundle shown here, we go over to V1 and our wide QRS, and the terminal half is above the 0 line. So we know the right ventricle's the guy who didn't get activated. We go to see our typical morphology, R, S, R prime in V1, deep wide S waves in 1, AVL, V5 and V6. When you have a left bundle branch block, you always have an abnormal heart. When you have a right bundle branch block, you can still be normal. something like 1.5% of all Air Force recruits. So a right bundle branch block does not necessarily mean disease. When you see a right bundle, you can't say anything about the right ventricle, but the left ventricle is still fair game. So we can still see evidence of myocardial infarction or hypertrophy and the like by looking at the left ventricular QRS. Now, one thing of note about right bundle branch block is that since the right ventricle points right and anterior, and the left ventricle points left and posterior, with them no longer depolarizing at the same time, it may become very confusing when you try to figure out a mean electrical axis. And since the right ventricle is the second sister of cardiology, what we'll do is discard the right ventricle for calculation of axis. So if I look at this and say, well, what's the mean electrical axis? I'm only going to look at the first 60 milliseconds. I'm going to use my left ventricular QRS for axis and just discard the terminal component. That's just making the same point. Moving on to hypertrophy, just like in the atria, we're going to see several things that will change our QRS morphology now. Number one is an increase in voltage. That increase in voltage from either of the chambers may create an axis shift. We may see repolarization abnormality because of the change in the myocyte physiology, which may shift our ST segments and change our T-wave vector. And lastly, as the myocytes grow in size and thickness, we may alter intercellular communication and change our QRS duration. And that's true of either ventricle. With left ventricular hypertrophy, the increased voltage creates what's known as posterior rotation of the QRS. I'll show you what I mean by that in just a second. The altered intercellular communication may give us a left axis deviation, increase in QRS duration, and the repolarization abnormality is going to show up where the left ventricle is dominant. So that's 1, AVL, V5, and V6 because they're over on the left side looking at the left ventricle. And when I was talking about posterior rotation of the QRS, I'm talking about in the horizontal plane. Since the left ventricle is depolarizing back towards the scapula, the guys that get to see him, V5 and V6, are going to see their R wave grow in height. Meanwhile, the guys on the other side of the coin, V1 and V2, see their S wave increase its depth. Now, that combination of observations has given numerical value that allows you to assign voltage evidence of LVH. The one that you're all probably familiar with is the R in V1 or V2 plus, or V5 and V6 plus the S in V1 or V2 greater than 35 millimeters. Now, that's true in adults over 45 years of age. And younger people are still more prone to exercise and have less adipose between the electrodes and the heart. You're allowed to have more voltage. At age 20, you're allowed up to 60. At age 35, you're allowed up to 45 for these criteria in Sokolov. Now, the most accurate voltage criterion is one known as Cornell, because the limb leads also change with LVH. What Cornell does is combines the limb leads and one of the chest leads to make a diagnosis. And for Cornell voltage, you take the R in AVL plus the S in V3. If it's greater than 20 in a woman and 24 in a man, that's voltage evidence of LVH. Now, some textbook sources use 28. Some other reference sources have used 26. So there's some variability in the threshold for LVH diagnosis in a man. Now, when you have voltage criteria for LVH, you got about a 50-50 shot you're right. So when you see voltage criteria, you go seeking the non-voltage criteria. And those are concurrent left atrial enlargement, axis shift, increased QRS duration, and the typical STT abnormality, which is sometimes called the strain T wave. It's a backward shaped check mark appearance of the T wave. That T wave can dive so deep that it starts pulling the ST segment down with it. So you may see even a little bit of ST segment depression. The mirror, now that's going to be most prominent in 1, AVL, V5, and V6. Looking from the other side of the heart, the mirror image of that's going to be in V1 and V2, where you may see a tall asymmetric T wave that may start to drag the ST segment upward slightly. When you see this repolarization abnormality of LVH, you can swing a gavel. You know the patient has LVH. You're very specific in your diagnosis. But it's not a very sensitive finding for LVH. And it tends to indicate a pressure-loaded chamber, like poorly treated hypertension or aortic valve stenosis. Example shown here, the S wave in V2 plus the R wave in V5, the combination is so great that I don't even need to know what the age of this patient is to say, yes, he's got voltage criteria for LVH. Meanwhile, I look for evidence of left atrial enlargement. That's not present. I look for an axis shift, positive in 1, negative in F, but lead 2 is still net positive, so my axis is still acceptable. I look for evidence of STT abnormality, and I've got my asymmetric T-wave inversion that's even dragged my ST segment down. So I say left ventricular hypertrophy, pressure-loaded chamber. The right ventricle is a lot more difficult to look at because it has to grow greatly in mass before it can begin to compete with the left ventricle. But what we're going to see as it gets large is anterior rotation of the QRS, because our right ventricular vector out the right breast is going to start to pull the net between the two out towards the sternum. The altered intercellular communication may give us right axis deviation. We may increase our QRS duration into what looks like a right bundle branch block pattern. QRS duration generally is not going to exceed 100 milliseconds, however. And we may see a repolarization abnormality in leads overlying the right ventricle. That's V1 through V3. Now, the interesting thing about this right bundle branch block pattern is it tends to be seen in a volume-loaded chamber, like an atrial septal defect or tricuspid valve insufficiency. And conduction is not actually slowed. The myocytes increase in their cross-sectional areas so that their conduction velocity actually goes up. But the increase in the length of the myocytes exceeds the increase in conduction velocity. So the ventricle in total is activated more slowly because the myocytes got longer, which is, I think, kind of cool physiology. Here shown graphically, if we're going to try to rotate our QRS, we're going to rotate it out towards the right ventricle. What's going to happen then is my R wave is going to grow in height in V1 and V2. My S wave grows in V5 and V6. So my criteria for RVH, and there's no numerical values for this, is right axis deviation, R greater than S in V1, S is deeper than R in V6, the incomplete right bundle pattern with a slight delay and our slight increase in QRS duration, the backward shaped check mark in V1, V2, and concurrent right atrial enlargement. Now, this is an example of right ventricular hypertrophy. Start with what's the mean what's the mean electrical axis? Normal or abnormal? Abnormal, and we're net negative in lead 1, so we're automatically thinking right axis deviation. Then we go to AVF, it's net positive, right lower quadrant. Find our isoelectric lead. AVR is net positive even, so we go find in lead 2 it's isoelectric, so we have an axis of 150 degrees. Automatically we're thinking RVH, so we go down to V1. Indeed, it's all R wave. We go to V6, the S is deeper than R. So I've got very good evidence of right ventricular hypertrophy. Repolarization abnormality, V1 and V2, indeed that's present. So I can swing a gavel. Now I'll ask you, is there evidence of atrial enlargement on this ECG? I go to lead 2, I've got a very tall P wave. It's almost 4 boxes tall. That suggests right atrial enlargement. Come down here to V1, I've got deep terminal negative deflection here. Very deep and wide, evidence of left atrial enlargement. What anatomic diagnosis would fit for this constellation of findings? Left atrial enlargement with right ventricular hypertrophy. Any guesses? Mitral what? Well, mitral stenosis. Yeah, this is the classic ECG of rheumatic mitral disease. The only way to make it better would be to have the patient in coarse atrial fibrillation. Now we're going to move to evidence of myocardial infarction. And to start with, understand the activation of the ventricles. Your His-Purkinje system penetrates the cardiac skeleton, splits into the right and left bundle. And the left bundle then fans out throughout the endocardial surface of the left ventricle. And as it does, it carries the message. It says, okay guys, let's depolarize. So what's going to happen now is, and this is something that always used to confuse me, taking the monophasic action potential and making it into a QRS on the surface ECG. What happens is that signal, hey guys, let's depolarize, is that spreads through the heart. We're going to have a net potential difference in our electrical forces in different regions of the heart. As that spreads through, that's where we get our QRS. Once everybody's finished with their upstroke of the monophasic action potential, we're going to have a plateau phase. During a plateau phase, everybody's depolarized to the same degree, roughly. So now we're going to go back to 0. And on my surface ECG, I'm going to have my ST segment, which essentially is registering 0. Then when we repolarize, something really cool happens. We repolarize from the outside in. The Purkinje fibers started on the endocardium, said, guys, let's depolarize. It spread from inside out, we got our QRS. Everybody's at the same, and the ventricle's contracting, we have ST segment. Now the epicardium actually repolarizes first. And evolutionarily, there's an advantage to that. That way the signal to depolarize can only go in one direction. It's a scorched earth policy. It can't turn back to the endocardium and re-enter on itself. When it does, that's called ventricular fibrillation. So this interesting quirk of nature then allows our T wave to point in the same direction as the QRS. It's the reason T waves and QRSs go in the same general electrical vector. Now if I change that somehow, well, the first way to change it was what we talked about earlier, and that's a block. But another way to change it would be to kill the Purkinje fibers in a certain region. If I do that, I don't allow this chunk of heart muscle to participate in that initial sweep of depolarization. What's going to happen is the first 40 milliseconds of my QRS is going to undergo an axis shift, which we're going to call a pathological Q wave. Everything's going to point away from the infarct zone. So shown graphically here, I've killed this region of Purkinje fibers. So now as my heart gets the message to depolarize, everybody says, okay, let's go. Well, these guys are left behind. So instead of my QRS pointing in an average direction for the whole heart, now, at least for the first 40 milliseconds, it points away. And we get this pathological Q wave. Pathological Q is at least 1 box wide and at least 25% the size of the subsequent R wave. It's normal to have Q waves in some leads on the ECG. For example, AVR. Remember, everything's happening and running away from AVR, so it may have a Q. Very small Qs may be present in V5 and V6 and one in AVL, and that's perfectly normal. But they won't be 1 box wide and they won't be 25% the size of the subsequent R wave. When you find a Q, the lead that you find it is tells you something about the anatomic location of the infarct. V3 and V4 are generally designated as anterior wall of the left ventricle, V1 and V2 septal, 5 and V6 anterolateral, 1 and L are called high lateral or just plain lateral, 2, 3, and F are diaphragmatic or inferior wall. This designation is actually useful because it helps tell you which artery may be involved in myocardial infarction. And lastly, a type of non-Q infarct is posterior infarct. When the posterior wall can't participate, what happens then is everybody on the front is overrepresented. So we get a very tall, fat R wave in V1. Generally, you're going to see infarcts come in combinations. For example, you see Qs from V1 through V4, and that's called anteroseptal. Or we may have anteroseptal and lateral. And posterior infarct tends to migrate with inferior because the right coronary artery most commonly feeds the posterior wall. Now, before I move on to show you some example, I want to make one point on ST segments. When we talk about infarct, in ECG speak, I'm saying pathological Q waves. It's the only way I can tell there's myocardial infarction. Now, if you have a history and physical examination and cardiac marker determinations, you can tell there was myocardial infarction independent of the EKG. But for ECGs, we've got to have a Q wave. When the ST segment shift, it's going to be evidence of injury. Now, you're injured for a period of time before you complete a myocardial infarction. And lastly, when T wave changes, they're very sensitive to ischemia. They're the things that tend to come first. So when we discuss ECGs, if we say myocardial infarction, we're saying Q wave. If we say injury, we're referring to the ST segment. And if we say ischemia, we're referring to abnormalities in the T wave. Now, when you go to minus 90, you go to your resting potential, it requires energy to get down there to create the electrical gradient. If a cell has trouble with its energy supply and it can't get to minus 90, it's said to be injured. So what would happen then, if I've got a region of the subendocardium here, and it leaves its negative charges laying around all outside the cell, where they're going to seek their opposite. That creates essentially a current in diastole. While nobody's depolarizing, everybody's at resting potential, everybody's supposed to be at the same electrical potential. If they're not, I've got a current during diastole. So then, instead of being at zero, I'm actually seeing a current come towards me in diastole. So the lead that's overlying that is going to register a positive deflection. Now, since we don't really start on our recordings with a true zero line, you don't get to see this upward shift. When the cells all complete depolarization, well, they're all going to depolarize to the same plateau phase. So there's going to be no net potential difference between one part of the heart and the other. So when I get to my ST segment, it's telling me my true zero line. What happens then, since we don't have a true zero recording, and all we're seeing is this part of the QRS, is it's going to look like the ST segment has been shifted downward. When in fact, at the same time, or the truth is, everything else has actually been shifted upward, and the ST segment's the guy who's telling us the true 0 point. Now that's a terrible oversimplification, but it makes it fairly easy to understand it. Now, if my injury then gets all the way to the epicardium, if my lead's looking here, he's going to see an electrical current running away from him in diastole. So we start here, he's going to see negative deflection in diastole. You finish depolarization, we get back to the true 0 point, and the ST segment appears to have been shifted upward. When you see an ST segment shift, and it's shifted downward, that's said to represent subendocardial injury, because we know it hadn't gotten all the way through to the epicardium yet. When you see ST segment elevation, or the appearance of ST segment elevation, that's said to refer to epicardial current of injury. Subendocardial injury, there's only really one kind. Epicardial currents of injury can be due to ischemic injury or myocarditis or even pericarditis. Now, this is an example. But first, what's the mean electrical axis? Is it normal or abnormal? Yes, normal. And you can see after, this is what, about the 10th tracing, you can see with a little bit of practice, normal or abnormal will take you about a second, and getting to a number will take you about 3. So I'll point out here, we've got what appears to be ST segment elevation in 2, 3, and AVF, so evidence of inferior epicardial injury. Now you say, well, is that an infarct yet? Look for Qs, because infarct equals Q waves. And in these same leads, I don't have a pathological Q. I've got one here in lead 3, but I need to have 2 leads side by side with a pathological Q to say there's evidence of infarction. We even have a little injury current in V5 and V6. So if I had to write down a diagnosis, I'd say that this is sinus rhythm, normal mean electrical axis. I've got inferior and anterolateral epicardial injury. And if you look in lead 1 and AVL and V2, I have the appearance of ST segment depression. Now these guys may actually just be seeing what's going on down here from the other side of the heart, or there may be true subendocardial injury. You can't look at the shape of this and tell the difference. So I'd call it lateral subendocardial injury or reciprocal change is what it's referred to when you're seeing the mirror image from the other side of the heart. Now with an infarct, we can tell roughly when it occurred by the morphology of the QRS, the ST segment, and the T wave. To start with, ST segments start up within seconds to minutes of closing an artery. So we do this frequently in the cath lab when we're trying to open an artery. We blow up a balloon and close it temporarily. After it's up a minute or two, the ST segments start to go up. That may last for up to 4 hours. By about 4 hours, the ST segment starts to turn around. And as the ST segment goes down, it pushes the T wave over and starts to push a Q wave down. So by about 4 hours, we start to see our Q wave, ST segments coming down, and our T waves flipping over. Now that appearance may go away within the next few minutes, and particularly if you reperfuse the infarct, or it may last for up to 2 weeks in a normal evolution. So there, I've got a Q wave, so I know I've got a myocardial infarction, and I know it happened sometime in the last 2 weeks. So that's termed infarct acute. By 2 weeks, the ST segment has gone back down to normal and flipped my T wave over. That appearance we know is present by 2 weeks, and it may last forever. So if I see a Q wave with a T wave that's inverted, I say I have a myocardial infarction. I have no idea when it occurred. Infarct, age undetermined. Now if you look at computer interpretation of ECGs for patients that you're dealing with, they probably all say age undetermined. The computer hadn't figured this out yet. After 6 months, smaller infarcts may see their T wave normalize. So I see a Q wave and a positive T wave. I'm going to call it infarct old. And lastly, 30% of inferior infarcts that tend to be smaller, beyond 3 years, can actually lose the Q. The fibrotic segment can essentially retract so that we activate around it and our Q wave melts away. You know what we're going to call that? Normal. If you don't have an old EKG, without a Q wave, you can't make the diagnosis of myocardial infarction. Now, caveats to this rule. One, if this appearance, Q wave and ST segment elevation, lasts longer than 2 weeks, it frequently represents a transmural infarct and often a left ventricular aneurysm in the territory. And lastly, sometimes your T wave can flip up right early, within the first few days after the myocardial infarction. That frequently represents peri-infarction pericarditis. Pericarditis creates an epicardial injury current, but one that is referred to as diffuse. Now the easiest way to see diffuse is to say, well, geez, every lead on the EKG except AVR has ST segment elevation. That's sometimes the case. What I find more useful is to look at 1, 2, and 3 in the frontal plane. If you have ST segment elevation in 1, 2, and 3, no myocardial infarction can give you the same vector. So that is the diffuse vector of pericarditis. The other thing about pericarditis is that the contour of the ST segment stays normal. It keeps that saddle-shaped contour, whereas ischemic injury tends to kind of blow the ST segment up into the T wave, whereas with pericarditis we keep our normal saddle shape or contour. And you see here we've got ST segment elevation in 1, 2, and 3. Prior to the era of modern imaging and cardiac marker studies, etc., the distinction of pericarditis often required serial tracings and the evolution that's distinct and different from that of ischemic injury. With pericarditis, you'll have ST segment elevation, usually for about a week or so. The ST segment goes back down, but it doesn't flip the T wave over. And of course it doesn't cause Q wave. But the ST segment comes back down and you have a period where it looks normal. After that, it's going to ruin the T wave. And it ruins the T wave in pretty much every lead. So you get very small, low amplitude T wave inversions in all of the leads where you had ST segment elevation, called a non-specific T wave abnormality. When we talk about ischemia, remember Q wave is infarct, ST segment is injury, T wave is ischemia. What happens here is, remember I told you that when we depolarize in our endocardium, the action potential lasts longer there, so we normally repolarize from the epicardium in. Now what happens when you become ischemic, the first thing that happens is the myocyte realizes I don't have much ATP lying around, I'm running out of energy. So the first thing it does as a method of trying to use less energy is to truncate the action potential somewhat. You have a potassium channel called IK-ATP. When there's no ATP around, it starts to open and push that action potential down so it uses less energy. And the subendocardium tends to be the first area to become ischemic. So what happens then is the region that's ischemic, the T-wave vector flips over. The short version of that is the T-wave runs away from treble. So where you see evidence of T-wave inversion, that may reflect local ischemia. So when we're talking about coronary disease and myocardial ischemia, Q-wave's infarct, ST segment injury, which means you're probably going to spill enzyme, and T-wave is ischemia. Lastly, hyperkalemia. It's the only electrolyte we'll really discuss. With evidence of hyperkalemia, the first finding that you see is your T-wave tends to become very tall, disproportionate to the QRS, and it becomes very pointed. So you get an EKG, you see a T-wave you wouldn't ever want to sit on, hyperkalemia is your first thought. However, the T-wave doesn't stay like that. So the potassium 5.5 to 7 or so, your T-wave is going to show up like that. But when hyperkalemia becomes very severe, you don't have that same shaped T-wave. What will happen is the P-wave amplitude will diminish, the QRS duration will tend to grow into your T-wave. So you'll get what's called a sinoventricular rhythm. The sinus node's still depolarized, but it can't capture the atrium. But the message can still get down the specialized conduction system and get to the ventricle, where depolarization is really messed up. So we get a QRS, the best example is shown here. Our QRS goes out and merges into our T-wave, giving us appearance that's often termed a sine wave QRS. So this is severe hyperkalemia. We're talking between 9 and 11, potentially or near fatal hyperkalemia. So it starts with the T-wave abnormality, but the T-wave abnormality is less prominent as hyperkalemia becomes more severe. So I think that's the high points for EKG. We won't have time to go through rhythms really today. I've got examples of the major abnormal rhythms in that handout. Really the only important ones to spend any time looking at are atrial flutter, because that's always fair game for a test because it's so obvious, and ventricular tachycardia. So what we'll do next time is I'll give you a series of tracings. It's either 15 or 20 tracings. I'll ask you to use the quotes of Bill Peterson, former coach for Florida State. I'll ask you to pair up in groups of 3 and interpret the ECGs for yourselves. And that does us just in time for lunch.